ಐ ಏನು ಕವರ್ ಆಗುತ್ತಿಲ್ಲ ಇದು ಕವರ್ ಆಗ್ತಿದಿಲ್ಲ ಅಷ್ಟೇ ದೊಡ್ಡ ಪ್ರಮಾಣ ಎಷ್ಟು ಈಗ ಅವತ್ತೇನ್ ಮಾಡಿದ್ರು ಹಿಂಗೇನಾ ಅವತ್ತೇನ್ ಮಾಡಿದ್ರಿ ಅವತ್ತೇನ್ ಮಾಡಿದ್ರಿ ಇಷ್ಟೇ ಬರೋದು ಮೂಲ
Thank you all. I request Dr. Manoj sir for welcome speech.
Present volunteer. It gives me an immense pleasure to deliver today's welcome speech. First of all, I would like to welcome the most encouraging, ever supporting, dynamic personality of this institution, Dr. Syed Atar Fatima ma'am, Principal, T.G.A.M.C. Ballari. I request Farida Begum Sheikh ma'am, Professor, Department of KAYACHIKITSA, to welcome ma'am with a token of love. Thank you, ma'am. The strength of Department of KAYACHIKITSA, the most dedicated, determined, creative personality, Dr. Madhav Digavi, Professor and Head Department of KAYACHIKITSA. I request Dr. Sam Kishore Singh sir to welcome Dr. Madhav Digavi sir with a token of love. And we have one more dynamic personality, Dr. Sampada ma'am, Professor Wims Ballari, Department of Anatomy. So I request Dr. Pushpalata ma'am to welcome Dr. Sampada ma'am with a token of love. Also, I welcome all the staff members, PG scholars, and UG first year scholars for this occasion. Welcome, welcome one and all.
Thank you, sir. I request Dr. Madhav Digavi sir for keynote address. Only 25 students. Don't. In spite of
Sri Dhanvantari. Salutations to Lord Dhanvantari and all the veterans and legends of Ayurveda, and to the lotus feet of Pandit Taranathji. Today is a fantastic day in the Department of PG Studies in KAYACHIKITSA that our PG scholars have planned to organize one-day CME on Shukra Dhatu as directed by our beloved principal. Now our principal has her focus and vision on academic activities. She has completed the infrastructure issues. She has completed all necessary equipments, the basic needs, extension of the buildings. That is, anatomical work is finished. I think further coming, the leaders of the institute need not worry about structural growth of the institute. That much development has been carried in 4 years of Madam's tenure. Now it is the time to develop the physiology, the working pattern of academics. With this vision, our principal asked us to conduct one CME for exclusively first year undergraduate students, because our institute is coming up with various advanced technology, instrumentation, biomedical engineering equipments, and various other WHO based standard analytical equipments in all departments. So let us sensitize our first year BMS students so that they should know that what is there in the syllabus. And more than that, we have better standard equipments in our institute. Like andrology establishment in Department of KAYACHIKITSA. It is the second equipment in Karnataka state. After Manipal Medical College, Kasturba Medical College, Manipal, the only institute having andrology setup is Tarnath Government Ayurvedic Medical College. So this should be focused to the beginners so that 5.5 years they will stay in the institute campus. They should know that what's going on. In every department, the undergraduate students should know what is going on. And another important thinking of our madam is, I really like that she has got a dream that for first year BMS students, some of the very exclusive clinical points are there for syllabus. And for that, the first year staff may not be the expert. If I read the physiology syllabus of BMS, I think I cannot pass if I get admission now. That much modern physiology is added, cardiological clinical bedside examination, neurological bedside examination, whatnot. All ultra modern clinical science is added in the first year BMS. And you will be shocked to know in first year MBBS question papers of anatomy and physiology, they don't ask write the structure of humerus. They will not ask directly the pelvis of male and female. This is all old style. Now they will ask applied questions. I hope they will give you a surgical problem. They will give you a clinical issue related to the anatomical structure. They will twist the question. And the first year MBBS student should know the clinical aspect of that bone or that structure. This much of very tough questions are coming for them. I hope it's not so in case of our undergraduate students. You are getting direct questions. Still, you are lucky. But in the practicals, lot of clinical material is there. Like semen analysis is asked for you. The normal values of semen analysis is asked for you. Then it is not necessary that the first year teacher knows all those things. Because specialty wise, system wise, so many advancements have taken place. Those advancements from the clinical department teachers must be taught to the undergraduate first year students is the dream of our principal ma'am, which is the unique trial under NCSM academic schedule. So we respect you, madam, and respect your dream. That when madam said about this to me, I said, yes, why not? By this, there are two advantages. One is our PG scholars will learn better. When they organize, they will learn better. And one who is working on this particular andrology clinical research, they will be more benefited. And as a KAYACHIKITSA PG scholar and other PG scholars who have shown interest, many of the PG scholars of various departments have shown interest there. They also want to learn. Of course, from even Goa state, from Maharashtra, a lot of inquiries were there for me to share the link of today's online deliberations. That they want to learn. Many of the PG scholars said we want this opportunity to be utilized. Staff members were also asking. So we have shared our link. This offline may be a small auditorium, but online will be very big. And people can read that online for any time. Any number of people can go to the link and know about the happenings in this today's year. For this, we have a history. In Gujarat Ayurveda University, when I was a PG scholar, there was a tradition of working on andrology. Now, current B.L. Mehra, who is one of the authority body for Government of India, he was the first person to start this initiation. Where it was an initial step. He is the principal of Kapula Government Ayurveda College, Himachal Pradesh. After that, Dr. B.S. Prasad, the ex-principal of KLE Institute, Belgaum, and currently he is the Board of Ayurveda President, NCSM, New Delhi. He started establishing the laboratory of andrology, semen analysis protocol. For that, I was the most junior in the paradigm, and we went to Dr. Rupin Shah, Mumbai, a famous andrologist at that time, and we started learning about semen analysis as per WHO. in KAM Medical College, Mumbai. Then we developed the same semen analysis methodologies in our PG department. I remember Professor Gurdeep Singh, my guide and the dean of Gujarat Residency at that time. He was kind enough that he gave the HOD chair to us and start development of semen analysis laboratory. He gave a clerk, he gave all the financial support to develop this, and based on that, we came back to our cities and we started practicing semen analysis plus andrology and male infertility. It was my bread and butter from the time of 1998 when I came to my practice. I started Shuddha Ayurveda practice based on modern investigation methods. Madam, we have Ayurvedic style where we integrate not by prescribing alone. Cross practice is not integration. Integration is that where scientifically the modern technology and science will be utilized for diagnosis and assessment. Professor K. Nurpa from Banaras University developed a protocol that Ayurvedic diagnosis, next modern diagnosis, then Ayurvedic intervention, assessment by Ayurvedic methods and assessment by modern methods. This is our basic mantra for development of KAYACHIKITSA and Vajikarna lab. The same we have continued in our private practice and same we are developing in our academic activities. I know that one of the first batch outgoing students of our KAYACHIKITSA department, after 3 years of rigorous training, they voluntarily said when they were going out of the institute that, sir, we will practice Ayurveda only. This was their inner conscious that they came to know that this has got a potential. So by doing CME and Shukra Dhatu, it is a syllabus point for first year BMS students. It is also a syllabus point for final year students. It is also a syllabus point for first year PG and final year PGs. And it is also useful to all allied clinical and basic departments of Ayurvedic research, that any student of Dargaguna, Rasashastra, Vaishajya Kalpana, Shillatantra can make use of this knowledge and develop their clinical career. Rather than practicing cross-practiced medicines, a person who practices allopathy system after Ayurvedic qualification will feel low esteem. He cannot raise the head in the market and talk to any medical profession people. Since 30 years of my graduation, not even a single allopathy pharmacist or medical representative is allowed in my clinic. So they gave Ayurvedic doctors response and respect to us. There will be no clash between two systems of medicine. When we do Kshara Sutra, we need some anesthetic support. If you take anesthesia support and do Ayurvedic treatment, it is well accepted by the market and even court. So in this respect, when Madam said about conducting CME for first year undergraduates, we started making discussion amongst our KAYACHIKITSA staff members and PG scholars that how to do this CME. Then it was a consensus that we will call the authentic person in anatomy and authentic person in physiology, so that if they talk on male reproductive system anatomy and male reproductive system physiology, then it will be more authentic CME. Even we can tell about male reproductive, but we are not the authority. And even as a student of Ayurveda after 30 years of Ayurvedic journey, we can learn from the concerned experts. Like Dr. Sampada, when they approached her, she was very happy to accept that. Yes, I'll come and give a lecture. Because she has also presented her articles in international journals. She has got that credit. And one more intimacy to our college, Sampada, is her father-in-law, Sri Hari Kumar sir. He is one of our IEC member. He is the senior most principal in the physics, chemistry. He was the principal of Vadla College. He always graces as an IEC member, and he said, I recall his words. After attending our IEC meeting, he expressed in front of our principal ma'am that this much of expert IEC meeting and well executed IEC meeting I have not seen in medical colleges. This was the comment by one of the leading professor, Akhila Bharati Vidyarthi Parishad, the South Indian well-known personality about our institute. Then we thought Integration is morning 2 sessions will be by modern faculties, and after that Ayurvedic faculty will talk on Shukra Dhatu, followed by last session will be demonstration of our semen analysis live showing to the batches. At least we'll take 10 members batch and show you. For that, our postgraduate scholar like Pramod, Dr. Manoj, and Dr. Nalina, a new PG scholar, a female, she is working on andrology. This is the strength of women. They are not hesitating that andrology and reproductive medicine is not suitable for female. But she is bold enough that I'll work on that. See, it is a laboratory work where samples will be collected doing that. So in this way, this departmental activity is going on. So today we will present in front of you about the Shukra Dhatu, the seventh tissue. We have 7 tissues in where modern have got 4 tissues in their science. So we have our own system of classifying the tissues, and it is one of the highest tissue that respected man, we have different anatomy and physiology. It is not like a structural anatomy what you study. We have only applied anatomy. Where Ayurveda says the semen or Shukra is present in entire body, whereas testicular semen or testicular androgens are located to only to the reproductive organs. But Ayurveda says this Shukra is present in entire body. How to understand that? For that, we have a fantastic person, P.S. Prasad, who has worked throughout his life on andrology. We have taken out a new concept that stem cells are present in entire body. So these stem cells present in entire body, the totipotent cells, when time comes, they can convert into any tissue. So this is the stem cell engineering going on, where 6,000 years ago, Ayurveda was knowing that entire body stem cell can be converted into any tissue at any time when body requires. Like adipose tissue, stem cell or totipotent cell can be converted into the spermatozoa. I request Dr. Ashik, we are waiting for it. So the totipotent cells of bone marrow, Shukra is manufactured. So for that purpose, these stem cell theories are needed. We have requested Dr. Arun Kumar, Professor of Physiology, to put some light on these issues, stem cell and Ayurvedic concept of Shukra. Shukra is semen plus androgens plus stem cells. This is a new trend where only the first year BMS undergraduates who are fortunate enough to participate in today's CME will only understand. Whereas I don't know in how many colleges of first year BMS they will tell that Shukra means androgen plus semen plus stem cells and cytoplasm. This concept is not there in every BMS textbook because textbook writers are not always experts in all subjects. They will tell according to their fabricated information and publish the textbook. But CME is like this. If an undergraduate student in the beginning of the first year itself, their thinking pattern changes. Their vision and mission changes. So we expected all 60 to participate. Of course, 50% is present. All you are very lucky that you will develop your own career in Ayurveda with understanding of current technology and standards in your curriculum. So as per NCSM, you have a strict, vigorous curricular activities, assessment protocols. So for that, it is an opportunity for you that whole day, morning 9:30 to 4 o'clock, you will be exposed to many aspects of developments in Ayurveda and modern science. So make use of this, and all other allied PG department scholars who have shown interest is also a feast for you. You can also learn in first year PG, you have research methodology. For that also, these new technology, new terminologies, new explanations will be helpful. I don't know if you get a question in first year research methodology that design a research methodology for Shukra Dhatu. If you get a question like that in KAYACHIKITSA and research methodology, you will be benefited again by attending this CME, whether online or offline. On YouTube, you can also again and again watch this whole day's deliberation, which will be helpful for undergraduates, postgraduates, internists. So with our principal's permission, Madam said, whoever has got space along with their duties and adjustment in duties or classes or schedule, who have got time, they can come and participate in this. So with this, I am thankful to our beloved principal ma'am for giving a task. This is the task and the examination for us. So today whole day it is theory and practical exam for us, and we hope we will positively complete this and reach to the basic focus of first year BMS scholars as well as other PG scholars and staff members also. With this few keynotes, I am thankful to organizing PG scholars for giving an opportunity without taking much of your time between you and the guest speakers. I conclude my talk. Thank you one and all.
Thank you, sir. I request Dr. Rajshekar Rani. I request Dr. Saida Akhtar Fatima ma'am to speak.
Good morning, everybody. Respected HOD of Postgraduate Department of KAYACHIKITSA, Dr. Madhav sir. Head of the Department of Shukra Dhatu Andrology. Associate Professor Department of Anatomy, Sampada. Head of the Department Sharira Rachana, Dr. T.G.A.M.C. RMO of this prestigious hospital, Dr. Ravi Kiran, Dr. Farida, and all the teaching fraternity and my dear students. As appropriately said by Dr. Madhav sir, when I went through the syllabus of first years, I got an idea that students should have an in-depth knowledge of all the clinical material. They need to have a clinical exposure. Right? The subjects are framed in such a way that they have to have a clinical exposure in the first year itself. The idea came to my mind that few subjects are there which our teaching fraternity are well versed with. They have an in-depth knowledge, especially Madhav sir, who is working on this topic of infertility, and he has the in-depth knowledge of Shukra Dhatu and about this andrology. So I just wanted all my dear students to have, I wanted him to share this knowledge because I think clinical teachers can do justice to that particular subject with applied aspects. With this idea, I just gave him the task one day. I gave this task to so many professors, but it was he who implemented, and he implemented in such a wonderful way. He came up with the CME. I just asked him to take 2 to 3 classes for them. And I really appreciate this idea of conducting CME and inviting all the resource persons related to the subject. I really congratulate you, sir. As said by Madhav sir, yes, our vision was first to develop the infrastructure and provide all the basic necessity for the students. Then my focus is this, from this year, it is purely on academics. Because I know that medical education is amalgamation of both science, technology, experience and experiment. This is the amalgamation of science, technology, experience and experiment. So we wanted to provide an opportunity, outstanding opportunity to all the students so that to enhance their performance as professionals in future, and they can discharge their duties with confidence. This is the very idea. And we as a college, we as a college are committed to obtain academic excellence among all the Ayurvedic colleges by enriching our students with the update knowledge of research and also the prevailing scientific knowledge we want to give it to the students, and thereby we can enrich their knowledge. Our mission as an institute, our mission as a team leader and as a team is to nurture the mind of the students, to nurture and nourish the minds of the students so that they can become compassionate, benevolent, and they remain always sympathetic to the student, to the patients. With this idea, I just want to conduct CM is like this. Why on Shukra Dhatu? Because we, as you know, we have developed on the andrology law, Casa 2020. That I just want all the students to know about that, what is happening in the college. I have taught Sharira Kriya for 10 long years, probably. Even though we teach Shukra Dhatu, we know the concepts. We know the concept. We know the Nyayas. Right? We know that three doshas are the pillars of our health. We know about the Sapta Dhatus. And we know that how that Rasadhatu nourishes Rakta, Rakta nourishes Mamsa, Mamsa is Medha. And we know that Shukra Dhatu is formed from the Majja Dhatu, the essence part of the Majja Dhatu. We know that Shukra is one among the Dasha Pranayatana. We also know that Shukra is prevailing all over the body. It is not only present in the reproductive system. It is not just the semen which is ejaculated during the sexual intercourse. It is not just the seminal fluid. It is beyond that. Shukra prevails throughout the body. That is the concept, right? And we do the qualitative quantitative analysis of this phenomenon not by doing examination all these days. We do that by physiological examination of Shukra, and we do the analysis by the Sara, Shukra Sara Lakshana. All these years we used to say that this person is having that Shukra in a normal quantity and it is performing its function by physiological examination of that particular way, and also by seeing the Sara Lakshanas. For all the dhatus, we have Sara Lakshanas. Very well said. Even today, it holds good. And based on the Sara Lakshana, we used to say that this Shukra Dhatu is in normal quantity and qualitatively. We used to assess the function based on this qualitative quantity. This was the thing happening in the field of Ayurveda. But now it is advanced. We want to know that Shukra is not just that which is ejaculated during the sexual intercourse. It is beyond that. We want to understand that so many things, the estrogen, progesterone, the androgens, the pituitary hypothalamic axis, whichever is involved in the secretion of all that is Shukra. That is why he says Shukra Dhara Phala. There is Shukra Dhara Phala which is present all over the body, where the Majja, essence of Majja enters there by the action of Shukra Dhatu Agni. Proper Shukra Dhatu Agni function, the Shukra is all this is nothing but this hormonal involvement. Maybe it is testosterone, even the estrogen, because they say Shukra is present in male and female. Right? So in the female also it is there means, yes, testosterone is there in the female, estrogen, androgens are there in the female. Right? So, and Shukra is not only in the reproductive organs, because whenever there is a congenital anomaly, there is no formation of what is that? Reproductive organs, or it is being mutilated due to some surgery. Still, then the person remains. The Shukra Dhatu is there. Then what is the Shukra Dhatu? We have to understand in a broader sense, because Shukra Dhatu is one which gives virility, vigor, strength. Is it not? So it is something else. It is not just the seminal fluid. So to understand this concept in a broader way, I thought we have to give some scientific analysis for this particular topic. With that idea, we thought of conducting this CME on Shukra Dhatu, where Madhav Digavya, I know 100% will give justice for the topic. And also we have who is going to throw some light on that and make you understand what exactly is the function of this system, what exactly is the semen. So, with this few words, I wish all the students to be benefited by this CME, whatever queries you have first years, you have to, it should be a proactive and interactive session. It is not just sitting there and listening to the thing. It should be very proactive session. You, whatever doubts you have, whatever queries you have, you can just ask for the resource persons and you can clarify your doubts. Thank you so much, Dr. Madhavi, for giving me an opportunity to share that.
So we have one special announcement, and Rajiv Gandhi University of Health Sciences, Bengaluru, is promoting research mind and research mindset amongst undergraduate students. The third year BMS students are given financial support to do basic research. In that, one of our student, Mr. Rajesh, when he was a pre-finance student, he has taken up a research project on andrology again. As a BMS boy, I really appreciate him and his work carried on. A title called Clinical Study to Evaluate the Efficacy of Swayam Gupta the Churna in the Management of Shukra Dhatu with special reference to male infertility. Today, we are fortunate and we are very happy to announce that respected ma'am and all the audience that he has successfully completed the research work. He has submitted the project report to the university, and the university has sent a special certificate of completion of his clinical research. And after seeing that, I quote, Dr. Sampath Kumar, one of our associate professor in the commented, sir, his report, after reading this, I think that it is not less than a PG dissertation work. That much fantastic work is done there. Research doesn't require brilliance or 100% scoring top student or a bright student. It requires honesty, obedience, and hard work. For this, example is Mr. Rajesh, now who is internally in the department, and I request our beloved principal and Dr. Rashekar to hand over this certificate from university on this dance. I request Rajesh to come and receive.
ಅವ್ರಂತ ಮಾತುಕೊಂಡ್ರ ಸಾರ ದ್ರೋಣಾಚಾರ್ಯ ಹೆಸರು ಅವರಿಂದ
I call Dr. Rajesh to speak few words regarding his research project.
ಎಲ್ಲರಿಗೂ ಮುಂಜಾನೆ ಶುಭಾಶಯಗಳು ಹಾಗೂ ಶಾಸ್ತ್ರತೆಯನ್ನು ನಡೆಯುತ್ತಾ ಹಾಗೂ ನಂದು ಈ ರಿಸರ್ಚ್ ಪ್ರಾಜೆಕ್ಟ್ ಬಂದಿದ್ದು ಥರ್ಡ್ ಇಯರ್ ಇತ್ತು. ಆ ರಿಸರ್ಚ್ ಮಾಡುವಾಗ ಫಸ್ಟ್ ನನಗೆ ಗೈಡ್ ಅವರು ಸ್ಟಾರ್ಟಿಂಗ್ ಸ್ಟೇಜ್ ಅಲ್ಲಿ ಈ ತರ ಮಾಡ್ತಾರೆ, ಪ್ರತಿಯೊಂದು ಈಚ್ ಅಂಡ್ ಎವ್ರಿ ಸ್ಟೆಪ್ ಅಲ್ಲಿ ಸರ್ ನಾನು ಬಹಳ ಥ್ಯಾಂಕ್ಫುಲ್ ಆಗಿರ್ತೀನಿ. ಅಂಡ್ ದೆನ್ ಡಾಕ್ಟರ್ ಧ್ರುವ ಸರ್, ಮೋರ್ ದೆನ್ ಆಲ್ ನಾನು ಇರ್ತಕ್ಕಂಥ ಪ್ರಮೋದ್ ಸರ್ ಇರ್ಬೋದು, ಅಜತ್ ಮೇಡಮ್, ಎಲ್ಲ KC ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಎಂಟೈರ್, ಅಂಡ್ ದೆನ್ ಸ್ಪರ್ಧಾ ಮೇಡಮ್, ಡಾಕ್ಟರ್ ರವಿತಾ ಮೇಡಮ್, ಎಲ್ಲರೂ ನಂಗೆ ಬಹಳಷ್ಟು ಹೆಲ್ಪ್ ಮಾಡಿದ್ರು. ಇರ್ತಕ್ಕಂಥ ಲೆಕ್ಚರರ್ಸ್ ಎಲ್ಲರೂ ನಮ್ ಪೇಷಂಟ್ಸ್ ಏನಾದ್ರು ಬೇಕಿದ್ರೆ ಮತ್ತೆ ಅವರು ಹಿಂಗ್ ರಿಸರ್ಚ್ ಮಾಡ್ತಿದಾರೆ ಅಂದ್ರೆ ರೆಫರ್ ಮಾಡ್ತಿದ್ರು. ಸೊ ಇನ್ನೊಂದು ನಾನು ಇಲ್ಲಿ ಹೇಳೋದೇನು ಅಂತಂದ್ರೆ, ಫಸ್ಟ್ ಆಫ್ ಆಲ್ ನಾವು ಆಯುರ್ವೇದ ಬೆಳೆಸ್ಬೇಕು ಅಂತಂದ್ರೆ ಅದು ಬರೇ PGs ಮಾತ್ರ ರಿಸರ್ಚ್ ಮಾಡಿದ್ರೆ ಆಗಲ್ಲ. ಫಸ್ಟ್ ಆಫ್ ಆಲ್ ನಾವು UGs ಹಾಗೂ PGs ಇಬ್ರು ಸೇರಿ ಆದಷ್ಟು ನಾವು ಎಷ್ಟು ಬೇಗ ರಿಸರ್ಚ್ ಮಾಡಿ ಎಷ್ಟು ಬೆಳೆಸ್ಲಿಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡ್ತೀವೋ ಅವಾಗ ಮಾತ್ರ ನಮ್ಮ ಆಯುರ್ವೇದ ಬೆಳಿಲಿಕ್ಕೆ ಸಾಧ್ಯ ಅಂತ ಹೇಳ್ತಾರೆ. ಇಷ್ಟೇ ನನ್ನ ಮಾತು.
Thank you, Rajesh. We are proud to have you, such a dedicating and hardworking student in our institute. The bridge between knowledge and skill is practice. The bridge between skill and mastery is time. Today's first session on anatomy of reproductive system by Dr. Sampada ma'am, and second session is by Dr. Arun Kumar sir on physiology of male reproductive system. Third session is on Shukra Dhatu, stem cell, and life cycle analysis demonstration by Dr. Madhav Digavi sir. I request Dr. Pushpalata ma'am to render vote of thanks for this inaugural function.
Once again, good morning to all of you. I'm here to conclude the inaugural session of today's CMB program. First of all, I'm very much thankful to our beloved and respected Principal Madam, who is center of attraction today's occasion. Is always inspirative and enthusiastic to conduct all such academic activities. Thank you, Madam, for being part of today's CMB program. I'm also thankful to my beloved and respected Dr. Rashekar Gangesh sir, Professor, Head of the Department of Dravyaguna. Thank you for being a part of today's CME program, sir. I'm also thankful to beloved and respected Head of the Department of KAYACHIKITSA, Dr. Madhav Digavi sir, who is a dynamic personality and who inspires all the students to conduct such CME programs. Thank you, sir. I'm also thankful Dr. Sampada Madam, Professor, Department of Anatomy, for accepting our invitation, Madam, and gracing this occasion. Thank you, Madam. I'm also thankful my beloved colleague, Dr. Farida Begum Sheikh, Dr. Dept, and all various department HODs, our RMO, all my dear students, and thank you, Madam.
Thank you, ma'am. Without delaying much, I will like to start next session. I'm very much happy to introduce today's first speaker, Dr. Sampada ma'am. Ma'am has completed their MBBS degree in 2005 from T.G.A.M.C. Davangere, Rajiv Gandhi University of Health Sciences. Pursued their MD Anatomy in 2005 from T.G.A.M.C. Davangere, Rajiv Gandhi University of Health Sciences. Madam secured 8 university ranks in MD Anatomy. Madam has 15 years teaching experience in both UC and PG. Madam published 1 international paper, 4 national papers. Madam presently working on 2 research papers. Madam currently working as a professor, Department of Anatomy, Ballari. Now I request ma'am to start the session. Anatomy of male reproductive.
ಇದು ask Shivu and Dr. Mary.
Good morning, everyone. So, I'm really very happy to be here in one of the most ancient institutes of Ballari. And I think it was a very wonderful beginning by chanting the shlokas and praying the God for blessing us, and especially like, for all the doctors. And with due respects to Principal Ma'am, the Sir, and all the HODs of the college and the staff, and try to do justice with whatever the anatomy part which is related to the male reproductive system. So we shall begin with the lecture.
Come on.
So in today's lecture, we'll be just knowing about the detailed part of the male reproductive system. As sir already said, we'll just begin with a clinical scenario here. So suppose a 40-year male patient comes to you with a history of fall on its own at home, and comes a history with comes with a history of pain which is felt in the groin region, and it is radiating to the iliac and the back of the person. So this indicates that a differential diagnosis where there may be a torsion of the testis which has occurred due to the damage or to the pain which is being referred to that area because of the same innervation. So that goes in favor of torsion of the testis. So with this basic clinical scenario, so we are going to study the male reproductive system here. So under what headings we'll be studying? So mainly we'll just go through the structure and major organs of the male reproductive system and what are the important functions which have been described for them. Okay, so we are going to just trace the pathway of the sperm here. So like from where it is being generated and where it reaches to bring about the reproduction. So this is a picture of the side view of the male reproductive system. So where you can see, so the important organs involved in the reproduction, which will be identified as the penis, scrotum, and the testis, vas deferens, and few of the accessory glands which have been noted in and around the urethra. So what is this male reproductive system? So why is it important? So it consists of a number of the sex organs. So mainly the organs which are involved as a part of the human reproductive process. So what is its function? So why it is being told repeatedly that it becomes a very important organ for the generation of one after generation after the generation to maintain the genetic component. So it is helping in production, storage, as well as release the male gametes. So these gametes here refer to the sex cells, so which are involved in the production of the sperm. So sperm is the one, so which is the active sex cell, so produced by the gametes. So we are going to classify these male genital organs or the male reproductive organs into two divisions. So one will be the external genital organs, so that consist of the penis and the scrotum, and the internal genital organs, so which consist of testis, epididymis, then vas deferens, and the supportive glands like the accessory glands named as seminal vesicle, prostate, and that of the bulbourethral gland. So here you have the front and the side view of the male reproductive system. So where a section is taken at the level of the pelvis here. So the external organs which can be identified here are the penis. Then you have a sac or the bag-like structure, which you call it as scrotum. And lost within this scrotum, so you have the main organ or the gamete cell producing the extra organ, which you call it as testis. So this testis leads to epididymis. From the epididymis, you can make out, so there runs the vas deferens and it reaches on to the posterior aspect of the urinary bladder in case of males. So where it joins with the ducts from the seminal vesicle. So together they term it as the ejaculatory duct. So that opens onto the prostatic part of the urethra. So the urethra which runs within the prostate, you call it as the prostatic urethra. So as it enters here, so the main function of all these ductules will be to carry the sperm from the site of origin to the wherever it is required. So that will be the part of the prostate gland here. Then you can make out the penis, so which contains the penile urethra. So just we'll brief about the external organs, so which consist of the penis and the scrotum. So penis is the organ, so where the sperm is introduced, through which sperm will be introduced into the females. So that consists of mainly the spongy erectile tissue. So which is again of two varieties. So they are classified into the corpora spongiosa and the corpora cavernosa. So these are the spongy tissues which are highly supplied by the blood. So they will be like cavernous sinus tissues. So once they become filled with the blood, they become turgid. So and they perform their function. So these erectile tissues have been classified into two varieties. So one is the corpora spongiosum, the other one is the corpora cavernosa. The corpora spongiosum is the mass of the tissue which usually surrounds the urethra. So urethra in case of my males, it performs two functions. So one is primarily it helps in urination. The other one is through the ejaculation, it will help to ejaculate the semen. So this spongy tissue, so which immediately surrounds the urethra, so that you call it as corpora spongiosum. So it allows the rushing of the blood into it, and this will be helping in becoming the organ turgid. So then you have the surrounding that two or a pair of spongy tissues, which you call it as corpora cavernosa. So these are also the erectile tissues, which are mainly composed of the spongy material and highly cavernous, richly supplied by the blood. So both of these will be helping in transporting the semen along with the sperms. So the part of the urethra, so which runs within the penis, you call it as the penile urethra. So in case of males, so the whole of the urethra will be nearly 18 centimeter. So it is again divided into different parts. So the one which immediately begins just below the bladder, then you will have the membranous urethra, then the prostatic urethra, and the penile urethra. So all these, because of the very long course, so catheterization in case of males is a little bit tricky and it will be very difficult because the whole course will be almost a S-shaped bend. So in case of males, it is just females, it is just a 4 centimeter length of the urethra. So catheterization would be very easy when compared to the males. So that's why, so this part of the urethra which you are seeing here will be called as the penile urethra. Surrounding the tip, you can see there is a rounded or what is known as the head of the penis. So this region is called as the glans. Okay. So surrounding this, there will be a fold of the skin, so which covers the head of the penis. So that is called the prepuce. Okay. So these are the different parts of the penis. So one more region, so which holds the important part of the testis will be the scrotum. So scrotum is termed as a skin fold or a bag, so which is almost projected from the lower part of the anti-abdominal wall. So this will be helping the testis to perform the spermiogenesis or spermatogenesis. So why is this scrotum required? So usually the testis performs at its maximum whenever the surrounding temperature is lesser or little bit lower than the body temperature. So for the spermatogenesis, it requires a temperature which is lesser than the body temperature. So that is maintained by the scrotum. So that's why scrotum keeps the testis at a temperature which is slightly cooler than the body temperature. So what is this scrotum? So it is nothing but a cutaneous bag, so which is of the skin, so which is divided again into right and left halves. So it is by a median raphe or a septum, so which is going to divide it into two halves, and it will hosting the testis, epididymis, and the vas deferens. So those are the contents of the scrotum. So it will have the testis, epididymis, and the lower part of the spermatic cord. So this exactly or externally, this scrotum will be divided into right and left half by a median raphe or a septum. So this extends posteriorly onto the perineum till the level of the anus, and anteriorly it continues on the undersurface of the penis. So it will be usually, so what you can note on gross structure, the left half of the scrotum, it slightly hangs down than that of the right half of the scrotum. So this is attributed to the greater length of the left spermatic cord. So that is also noted when you see the gross appearance of the scrotum. So usually the left half will be hanging down a little bit than that of the right part of the scrotum. So these layers of the scrotum, they become very important because as we have seen, testis initially when it develops, it will be an abdominal organ. So it passes from the abdomen through the different parts of the abdomen, then through the inguinal canal and reaches the present position of the scrotum. So as it moves down, it will be carrying the different layers of the abdomen along with it. Okay? So the coverings of the scrotum, which you see, will be divided into the external most will be the skin anyway, or whenever you do the dissection, so usually the next layer which you come across will be the superficial fascia. But here, the superficial fascia is replaced by a muscle. So that is called the dartus muscle. Okay. So this dartus muscle replaces the superficial fascia in the scrotum. So the next layer which we come across will be the external spermatic fascia. So external spermatic, all these layers are derived from the muscles of the anti-abdominal wall. So as they come down, so we have three important muscles there: external oblique, internal oblique, and transversus abdominis. So when we come across the testis, as it descends down, it carries along with this the muscles, so which are layered as external spermatic fascia. So next is the muscle, so that is known as the cremasteric muscle, and the fascia. So usually this is the muscle which is seen along with the spermatic cord. So contraction of this muscle helps in the propulsion of the further movement of the semen or whatever the part of that area. Then the innermost will be the internal spermatic fascia. So this dartus muscle, which we have seen as a second layer, so this will be prolonged into the medial vertical septum, which we have seen, so that it covers entirely the scrotal sac, and this will be aiding the contraction. So it is dividing the scrotum into two halves. So here we can make out the layers of the scrotum. So externally it is covered by the skin. So immediately beneath the skin, you can note that it is nothing but the, instead of superficial fascia, you have the dartus muscle. Then external spermatic fascia. After that, you can note the thin muscle, which is identified here as the cremasteric muscle along with its fascia. Then the innermost will be the internal spermatic fascia. So deep to that, you have the testis along with its epididymis and the vas deferens, so the upper part of the spermatic cord being hanging within the different layers of the scrotum. So these are like protective to the testis, so which becomes very important, and also they aid in providing the proper temperature for the spermatogenesis. So as the scrotum is acting as a bag and it is found in the lower part of the perineum, so it is supplied by mainly the pudendal vessels. So especially the external pudendal, then the deep external pudendal, along with the scrotal branches of the internal pudendal. So few branches from the inferior epigastric artery can also be noted here, so which are in the form of cremasteric branch. So nerve supply, so the whole of the scrotum has got the dual innervation because it's been divided into an anterior third and a posterior two-third. So anterior third derives its innervation from the L1 part of the spinal cord in the form of iliac inguinal nerves and the genital branch of the genitofemoral nerve. Whereas posterior two-third, it derives its segments from the S3 part of the spinal cord. So the nerves will be posterior scrotal branches of pudendal nerve and perineal branches of the posterior cutaneous nerve of the thigh. Whereas the dartus muscle is supplied by the genital branch of the genitofemoral. So we have grossly studied regarding the scrotum and the penis. So next we'll go in detail regarding the internal organs or the internal genital organs. So important among them will be the testis, then you have the epididymis and the vas deferens. Along with that, they are supported by the accessory glands, so which are seminal vesicles, prostate gland, and the bulbourethral gland. So testis is very important male gonad, so which is going to give rise to the sperms. So this will be an oval shaped structure, so which is a male organ, so that produces the sperm and the hormone testosterone. So testis has got two functions. One is the secretion of the hormone, so that is in the form of testosterone or dihydrotestosterone. Then you have the production of the sperm. So that forms the main function of the testis. So these are the two testes. You have the right testis and the left testis, raised to the right and the left scrotal bag. So where there are oval shape in structure, and usually what are the different parts? So it measures around nearly 3.75 into 2 centimeters approximately. Then it will have an upper pole and a lower pole. So two borders are being identified, anterior border and a posterior border. Then two surfaces in the form of medial and lateral surface. So this is a dissected specimen of the testis where you can see. So this is the oval mass of the testis, so which is being covered by the different layers. So again, we'll go in detail regarding the different layers of the testicular coverings. So here you can identify the upper pole, then this is the lower pole, and there is an anterior convex border and a posterior border which is slightly blunt. Then we can identify the medial surface and the lateral surface. So why we call it as the two surfaces become medial and lateral here? This is because when we hold the testis, usually we hang it with the help of the spermatic cord. So what is spermatic cord? So this is the contents, so which is mainly in the form of a tubular structure, so which passes through the inguinal canal, so which has got the vas deferens along with the testicular artery, then you have aciniform plexus of the vessels and the nerves. So all these they form the part of the spermatic cord along with the cremasteric muscle. Okay, so this when we hang or hold these testes with the help of the spermatic cord in such a way that this posterior border, so this should be directed posterior lateral. So that helps you to identify the site. So this, whenever it is directed, so this part is called the sinus of the testis. So there is a gap because of the processus vaginalis, the developmental part between the testis and the head part of the epididymis. So this should be directed posterior lateral. So this will be usually a right testis. So whenever you hold the spermatic cord with in case of it a left testis, it should be directed towards the left and posterior lateral aspect of the left half of the scrotum. So that's how the anatomical position of the testis is decided. So what is this testis consist of? So each testis is made up of highly coiled structures, which you call it as the seminiferous tubules. So numerous seminiferous tubules have been identified in each testis, and among the tubules, so there are different cells, so which are involved in the production of the sperms and the hormone testosterone. Okay, so that will be the main function of the testis, where it is made up of actually the seminiferous tubules, which are the main part of the testis. So how the descent of the testis takes place? So this is an abdominal organ. So while developmentally it will be placed within the abdomen, so where it is almost lying in the region of lumbar part, that is between T10 and T12 level of the vertebra. So this is developing from the mesonephros, and as it descends down to reach the present position of the scrotal bag. So how it descends? So almost at the level of the third month of the intrauterine life, so it will be lying in the iliac fossa. So then it descends further and reaches the deep inguinal ring. So inguinal canal is the intern part of the external oblique muscle. So along with supported laterally by the internal oblique and the transversus abdominis. So this is a canal which is going to extend between two openings. So which you call it as deep inguinal ring and the superficial inguinal. So this almost lies above the level of the inguinal ligament, extending between pubic tubercle and the anterior superior iliac spine. So this holds the passage for the testis pass from the abdominal region to that of the scrotal bag. So at the third month, it will be almost lying in the iliac fossa, and as it descends further between fourth to sixth month, it will be lying near the deep inguinal ring. So almost at the seventh month, so it traverses the inguinal canal. And at the superficial inguinal ring, it will be found around the 8th month of intrauterine. So almost at the birth or during the 9th month, so it will be descended into the scrotum. So before that, usually in case of premature deliveries, if you see, you can make out the undescended testis, or because of the proper development has not taken place or it has not descended to the present position, 7th month delivery or an 8th month delivery, it will not be found in the present position. So it will take its own time to reach nearing the 9th month or about the birth to reach the scrotal position. So we'll just know regarding how it descends further into the scrotum. So what are the requirements for the descent? So one is the lower pole of the testis is attached to the floor of the scrotum by a mesenchymal tissue, so which you call it as gubernaculum. So before it was thought that gubernaculum contraction was the one which was responsible for the descent of the testis. But now it is noted that it is just a pathway, or it is directing the force of the testis to the scrotal bag. So it is the differential growth of the abdominal wall. So before it would be a very small space, the abdomen, as it grows further, it almost reaches through the inguinal canal to the scrotum. And many have proposed theories regarding that many hormones are also responsible for the descent of the testis. So we'll just go through a small video how it shows the descent of the testis. Okay, later we'll visualize that video. So it is the descent of the testis which is being decided by the pathway for the gubernaculum, then the hormones, and the different pathway for the through the inguinal canal, where it reaches the presence total 8. So posteriorly, the testis leads to what is known as the epididymis. So epididymis, once the testis descends, the upper portion of it will be in the form of a tubular structure, henceforth. So this is nothing but a passage for the semen on the sperms to reach its target tissue. So here, the epididymis is nothing but the tightly coiled tubes, so which are found against the upper portion of the testicle. So this is being the main function of the epididymis is it is helping in the maturation of the sperms, and it is also a storage place for the sperms. So this is the area where it has got many phagocytosis process through which the worn-out sperms and the spermatids will be removed from the core. So that's the function of the epididymis. One is it is involved in the maturation, then it is involved in the storage of the semen, and it is also helping in removal of the burnout spermatids. So there are different parts of this epididymis. So one that is immediately lying at the upper pole of the testis, you call it as the head of the epididymis. So this head of the epididymis still has got the straight tubules or the efferent tubules. So it is having numerous tubular parts within the head. But all these merge together to form a single tube, and that continues as the body and the tail of the epididymis. So still it is convoluted because it has to hold the whole long length of the tubule. So that's why it gives a convoluted appearance to the whole length of the body and the tail of the epididymis. So this is the head, and then we have the body and the tail of the epididymis. So later this continues as the tubular structure, which you call it as vas deferens. So vas deferens, also known as the ductus deferens, it is a thick tubular structure. So this starts almost at the base from the epididymis, the tail of the epididymis, and it leads to the urethra.
The inguinal canal is a passageway through the abdominal wall that develops in both males and females. In males, proper development of the inguinal canal is an important event for the subsequent descent of the testicle into the scrotum from its initial site of development in the abdomen. Testicular descent takes place in two phases, the transabdominal phase and the transinguinal phase. The transabdominal phase is a passive process during which a band of mesenchyme, known as the gubernaculum, appears to tether the testis to the scrotum. The testis, which initially lies on the dorsal abdominal wall, develops between the peritoneum and the rest of the body wall. Between 10 and 15 weeks of development, the abdominal cavity enlarges, causing the anchored testis to be drawn downward to the mouth of the deep inguinal ring. During this descent, the testes travel in a lateral to medial direction. The transinguinal phase is an active process that takes place over a couple of days between 25 and 35 weeks of development. A finger-like evagination of peritoneum, called the processus vaginalis, pushes its way through the tissues of the developing abdominal wall. This evagination follows the course of the gubernaculum and acquires sleeve-like coverings of tissue corresponding to various layers of the developing abdominal wall. These layers, which develop into the transversalis fascia and the internal oblique and external oblique muscles, follow the processus vaginalis and become the layers of the spermatic cord, the internal spermatic fascia, cremasteric fascia, and external spermatic fascia, respectively. The leading tip of the processus follows along the gubernaculum and enters the scrotum. The testicle, together with the ductus deferens and testicular vessels, then follows. The testicle is able to enter into and move within sleeve-like layers of the developing spermatic cord surrounding the gubernaculum and the processus vaginalis by compressing the tube-like processes. The proximal end of the processus vaginalis normally disappears. The distal tip survives and becomes the tunica vaginalis. The remains of the gubernaculum form the ligament of the scrotum.
So this is how the testis is going to descend from the abdomen to the present position of the scrotal bag. So here, as it descends down, so it is going to carry the different layers of the abdominal wall, especially the muscles, then the peritoneum layer. So the peritoneal pouch, you call it as the processus vaginalis. So this processus vaginalis, usually it is descending like a pouch around the whole of the testis. So this is the one which is going to give rise to the outermost layer of the testis later, which you call it as tunica vaginalis. So that's why this video has been shown here, like how it acquires all the coverings or the layers of the testis. So most of the part of the processus vaginalis, it will be completely closed, except for the distal part which remains around the testis, so which you call it as the tunica vaginalis. So that again, like any peritoneum, anywhere in the body, it will have two layers, the parietal layer and the inner visceral layer. So similar to that, here also, as it covers the testis, so it will be again divided into two layers, the outer parietal layer and the inner visceral layer, which is going to cover the external aspect of the testis. So that is tunica vaginalis. So the remnant of the gubernaculum, which is almost holding the lower pole of the testis, so that is considered to be the ligament of the scrotum. So that was the main idea, which was to show like how it descends from the abdomen to the scrotum and what are the layers, how it is going to cover the testis. So this we have already covered. So this course of vas deferens here, it becomes important because so it is beginning almost at the lower pole of the testis. So as a small tubular structure, and then it ascends further, almost it travels near the abdomen, near the anti-abdominal wall, and again it enters into the pelvis. So along the course, anywhere here, if it is obstructed or it is being damaged due to any accidents or anything, so this can lead to the blockage of the vas deferens. So this is one of the common cause for the infertility which is caused in the males. So this long course of the vas deferens is one of the reasons where it can be easily damaged. So it ascends upwards, reaches the pelvis, so where it is going to reach the posterior aspect of the bladder, so where it is going to join along with the duct of the seminal vesicle. So these two ducts join together to form what is known as the ejaculatory duct. So this opens into the posterior aspect of the prostatic urethra. So this is how it carries the semen along with the sperms from the testis to the prostatic part of the urethra. So that is the whole course of the transport of the sperms from the epididymis in the anticipation of any ejaculation. So other accessory glands, so which have been identified in and around. So what is the function of these accessory glands? So here the sperm along with it is transported in a medium which you call it as the semen or the fluid. So this fluid or the semen, it is being added by the means of all these glands which are seen in and around the vas deferens and along with the testes. So among them, they are going to provide the nourishing fluid for the sperms that enter the urethra. So we have seminal vesicle, prostate gland, and bulbourethral gland. So seminal vesicles are the small sac-like or the honeycomb appearance sacs, so which are found on the posterior aspect of the male bladder. So these are attached to the vas deferens in the distal portion, where they join together to form the ejaculatory duct. So this opens into the prostatic part of the urethra, almost at the level of the uterus. So here you can see the main function of this seminal vesicle is to produce a sticky fluid. So this fluid will be rich in fructose, which is very much required for the spermatogenesis. So these are the seminal vesicles found on the posterior aspect of the bladder. Surrounding the bladder neck, almost a stone hard like gland will be identified. So which will be very hard and it will be almost like a stone feel when you touch the gland. So this surrounds the ejaculatory duct at the base of the urethra, just below the level of the urinary bladder. So prostate gland is the one which is responsible for the production of the semen. The prostatic fluid, whatever it is going to secrete, so it will be rich in the prostatic specific antigen and also the mixture of the prostate fluid, which is going to make it more alkaline and adding up to the seminal fluid. So that's the function of the prostate gland. And small glands which are found in the membranous urethra. So they are called the Cooper's gland or the bulbourethral glands. So these are found in the membranous part. So these are the different parts which I was telling you. So this is the beginning portion of the urethra. So where it descends from the urinary bladder, then it begins the prostatic urethra, which runs within the prostate. Then there is the perineal membrane, so which is just found below the level of the prostate. So that portion you call it as the membranous urethra, and the continuation within the penis you call it as the penile urethra. So within the membranous urethra, there are small loose glands which are identified or located on the sides of the urethra, so just below the prostate gland. So these glands are going to produce a clear slippery fluid, so which is going to add up to the semen and it directly empties into the urethra. Okay, so these are the three accessory glands which we have identified till now. There is a prostate, the other one is the seminal vesicle, and one more is the bulbourethral gland. So till now, what we have studied is mainly what are the main functions of the male reproductive system, so which is mainly involved in the production of the sperm cells. Then it is going to deliver them to the female reproductive system. And it consists of the external as well as the internal organs, so which are essential for the production or the continuous reproduction of the life. So next we'll study the histology part. So before proceeding to the histology, we'll just know a basic structure of the sperm, so which is the male gamete cell here. So that's main function is to move and carry the genetic material or the information to the egg, to the ovum. So the structurally it is made up of a head portion, then there is a middle piece and a tail which has been identified as a distal portion. So the head portion it mainly consists of the DNA content, that is the nucleus consists of the DNA. Then it will be having a large acrosomal cap, so which is made up of numerous granules, so which is almost completing and protecting the distal part or the anterior portion of the head. Then the middle piece, it will have a central axial tail. So that will be surrounded by a mitochondria, which is like a ribbon sheath, so which is going to surround this axial filament. Distally, you can identify a tail-like portion, which is called the flagellum or the tail. So this makes the sperm more motile. So this is the one which is helpful for the wave-like motion of the flagellum, so that propels the sperm further and helps in the motility. So where are these sperms produced? So these are produced through the basic germ cells, so in the form of sperm cells, so which by a process which is known as spermatogenesis. So spermatogenesis is the formation of the sperm cell. So this takes place within the seminiferous tube. So there are different stages. Like initially there will be mitosis taking place, then there is a meiosis where it is a reductional division, and this is going to give rise to four spermatids in the form of which are later undergoing a process called spermiogenesis, where it is nothing but the capacitation of the spermatid into a sperm, and it leads to the formation of what is known as the sperm. So single cell is going to give rise to four sperm cells. So here through a process of mitotic division. The primordial germ cell, so this is going to undergo mitotic division, which is going to give rise to primary spermatozoite. Then it undergoes the first meiotic division, which is usually a
reductional division, where the diploid number of the chromosome is reduced to haploid. So from the 46 to 23 chromosome. So further it undergoes a second meiotic division. So to give rise to spermatids. So these are still inactive stage of the sperm. So they are not motile because there is a further process called the spermiogenesis. That is called the capacitation of the spermatids to form the actual motile sperms. So that spermiogenesis will be taking place to give rise to 4 active sperm cells. So that is the process of spermatogenesis. So till now we have traced the pathway of the sperm in the male reproductive system as follows. That is, it is synthesized in the testis. So from there it is taken up by the epididymis. From the epididymis it reaches the vas deferens, and from the vas deferens it is going to enter through the ejaculatory duct into the penoid part of the prostatic part of the urethra, and there further during the ejaculation it will be released. So till now we have studied the gross part of the male reproductive system. So here we'll just go through a bit about the histological section of the testis, vas deferens, and the epididymis. So this becomes important because once we know the different parts of the male reproductive system, so where the sperm cells are synthesized, what are the different types of the cells, and what is the architecture of these different small parts, because any damage or any malfunctioning of this may lead to infertility in case of males. Okay, so first we'll go to the histology of testis. So this already we know that the male reproductive system consists of the testis, genital ducts, accessory glands, and the penis. And it has got a dual function for the testis. One is the production of the sperm, and the other one is the production of the hormone. So these genital ducts and the accessory glands, they are going to produce the secretions, which are going to add up the semen, and the contractile smooth muscles so help in the movement of the spermatozoa towards the exterior. So these secretions also provide nutrition to the spermatozoa, so while they are confined to the male reproductive tract. So once they reach further, so this spermatozoa and the secretions of the genital duct and the accessory glands, so all these are going to add up for the semen. So that's what you're going to do in the semen analysis, which will be further helped by the answer. So which will be like what are the contents of the semen. So here it will be having the spermatozoa and the secretions along with the different fluid parts which is coming from the genital ducts and the accessory glands. So although the testosterone is considered to be the main hormone, so which is produced by the testis, along with that one more active hormone from the testis will be through dihydrotestosterone. So these are necessary for the physiology in case of males. So this is the histological section of in case of the testis. So already I told you, so the external compartments of the testis will be guarded by 3 layers of the coverings. So the outermost, which one you call is the tunica vaginalis. So tunica vaginalis, so the next layer will be by the tunica albuginea, and one more is the vascular layer. So that will be the innermost, which you call it as tunica vasculosa. So these 3 layers are going to protect the underlying spermatozoa or the spermatids. So each testis receives the mesenchymal, or what you call it as the peritoneal covering in the form of tunica vaginalis. So this tunica vaginalis will have an outer parietal layer, then an inner visceral layer, which is almost attached to the surface of the testis. So just beneath that, you can make out there is a thick fibrous connective tissue. So this dense connective tissue is going to divide into numerous septa. So this is going to give rise to the different septas. So this is going to divide the whole of the testis into numerous lobules. Nearly 200 to 400 lobules have been identified in each of the testis. So these lobules are almost pyramidal in shape, conical separations separated by the connective tissue septa from the tunica albuginea. So they are nearly 250 pyramidal compartments, which you call them as testicular lobules. So these septa are usually incomplete. These come incomplete, and there is usually interlobular communication that happens because of the incomplete septa.
So posteriorly, this part of the thickening of tunica albuginea, you call it as mediastinum testis. So which is found in the posterior aspect of the testis. Then from there, usually the radiating like rays of a sun, you get the septum. So which is going to divide it into small pyramids. So each lobule is occupied by mainly the seminiferous tubule. So seminiferous tubules are nearly at least 1 to 4 seminiferous tubules will be identified in each lobule. So in a testis, you'll have 200 to 400 lobules. So if each lobule has got 1 to 4, it goes up to 600 to 900 seminiferous tubules in each testis. So that will be the length of the seminiferous tubules which will be found. So that's why it undergoes lot of convolutions or it holds on itself to occupy in a very small space. So that's why when you take a section of the testis, many convolutions or the round tubular structures can be identified. So that is because it's being folded on itself or convoluted because of the very small space available for a long length of the seminiferous tubule. Okay. So this is meshed, enmeshed, and it will be having a web or the loops of the seminiferous tubules. In between, there is connective tissue. So this interstitial tissue, you call it as interstitial because it is lying in between the lobules, almost like an in between the lobules. So there you find one more important cell. So that is called Leydig cells. So two important cells are identified here. So one is the germ cell, so which will be seen within the testis, so which is going to secrete the sperms. Then one more is the interstitial cell of the Leydig, so which is going to secrete the testosterone. Okay. So two cells, we'll go into in detail again. So seminiferous tubules are the one which are producing the spermatozoa in case of males. So this embryological development of tunica vaginalis already I have told you. So how it is going to descend from the terminal wall and it is going to divide into two layers covering the testis. So this is the section of a testis. So what you can see when you take a section of the testis is outermost covering. So that is the tunica albuginea. So which is thickened and it is going to divide it into numerous septa. So this septa will be nothing but consisting of the seminiferous tubules. And in between the seminiferous tubules, there is interstitium, so which consists of the Leydig cells. Okay. So some spermatozoids are produced in the seminiferous tubules almost at a rate of 2 into 10 to the power of 8 in the adult. So that is the normal synthesis which is going to take place. And each testicle so will be having nearly 252,000 seminiferous tubules. So that measure around 150 to 250 millimeters in diameter and 30 to 70 centimeter in length. So that is the length of each tubule. So that is why it is going to be highly convoluted to get placed in a small space. So combined length of the tubules of one testis, it is nearly measuring around 250 meters. So the tubules are convoluted and have the forms of the loops. So all these tubules are found in a small pyramidal shaped lobule. At the end of the lobule, so where we have seen the mediastinum testis. So what happens here? All these give rise to small tubules in the form of straight tubules. So those are called as the straight tubules or tubuli recti. And all these straight tubules, they merge together to form a mesh-like structure. So which you call it as the retate testis. And from the retate testis, it is going to give rise to 10 to 20 efferent ductules. So these are again the straight tubules which are heading towards the epididymis. Okay. So from the seminiferous tubules, they are giving rise to what is known as the straight tubules. They are going to merge together to form an anastomotic network, which you call it as retate testis. From the retate testis, it is going to give rise to 10 to 20 efferent ductules. So these are all engaged within the epididymis of the head portion or cephalic portion of the epididymis. So this is a histological structure which you are going to see when you observe a testis under microscope. So what are the different cells and how you are going to identify? So seminiferous tubules, these are the sections of the seminiferous tubules. They are lined by an epithelium which you call it as the germinal epithelium. Similar to the ovum in case of females, there is an outer covering called the germinal epithelium. So here there is an epithelium so which has got again different layers. So outermost covering there will be a basal lamina and this layer you call it as germinal epithelium. So here, few fibroblasts and the myoid cells are identified. So what are these myoid cells? They are nothing but the smooth muscle cells. So which are going to surround each of the seminiferous tubule, and contraction of this myoid cells is going to help to propel the sperm or the spermatids further. So those are identified in the surrounding. And here you can see the different layers of the cells. Within the seminiferous tubule, already we have seen how the spermatogenesis takes place and what are the different stages of the cells you have identified. So the basic layer, so this is called the basal lamina. Here you can see two types of cells. One is the supporting cell, or also known as Sertoli cell. The other variety of the cell is the what is known as the sperm or the germ cells. So these germ cells, the different layers of the germ cells are identified. So the larger ones, which are found in numerous adjacent to the basal lamina, you call them as spermatogonia. So they are more numerous in number. So these give rise to the primary spermatocyte through the mitosis. So they will be further reduced in size with a reduction in the nuclear content. And as they multiply or divide by means of meiosis, it gives rise to secondary spermatocytes. They will be further reduced in size with the less amount, because already the reductional division have reduced the chromatin content from the diploid to haploid number. And ultimately, they give rise to immotile structures which are called the spermatids. So these spermatids undergo a process of spermiogenesis to give rise to the sperms, which are usually the motile ones. So this adjacent to these germ cells, you can see one more elongated cell, so which is called the Sertoli cell. Sertoli cells is the nutritive cell or the supportive cell, so which is found at almost pyramidal in shape with a centrally placed nucleus. And in the tip, you can see almost all the spermatids will be found at the apical region of the cell. So the function of this Sertoli cell is mainly to produce the support system, providing the support system or the nutrition to the cell. So thus the spermatogenesis process has been identified here. You can see the numerous stages of the cell, the spermatogonia, then next stages of primary, secondary, and the spermatids are usually seen in the apical region of the each cell. So after the spermatogenesis, the final stage where spermatid acquires the maturity, so that is called the spermiogenesis. So this spermiogenesis, it undergoes through a complex process. So where you can see the distal portion of the spermatid. So it is a complex process. So where it includes the formation of the acrosome, then there is the condensation and elongation of the nucleus, along with the development of a flagellum. So this end result of a will be the mature spermatozoon, which is usually motile, and it will be released into the seminiferous tubule. So that is the process of spermiogenesis. Okay, so all these stages we have already identified. From the spermatogonia, you are going to get the primary, secondary, and there are spermatids which are going to get converted into the sperm. So how this happens is mainly because of the numerous organelles which are found within the cell. So especially the mitochondria, the Golgi complex, and the centrioles. So they align themselves in such a way that they will acquire an acrosomal cap near the head region, and there will be formation of a central axial filament, so which is forming the middle piece, and the mitochondria aggregates around this like a ribbon around the central axial filament. So distally, it will be having and acquiring a tail-like structure, which you call it as the tail of the sperm. Okay. So importance of Sertoli cells already I've mentioned. So this will be seen as a larger cell with a large nucleus in between the other germ cells. So how you identify? So this will be a larger cell with an elongated one nucleus, which is found in between the sperm or the germ cells. So the function of this will be, usually they will have invaginations around the basolateral portion as well as the apical portion. apical portion, you can see numerous spermatids are being clogging into the apical portion of the Sertoli cells. Okay, so this lateral will be the invaginations through which it will be holding to the other types of the cells. So main function of the Sertoli cells is to produce the nutritive portion and provide the germ cells and help in the maturation. So till now we have seen the structural part of the testis and the epididymis portion. So all these together they form an intratesticular genital ducts. So not only we have identified the extra testicular ducts in the form of epididymis, vas deferens, even within the testis we are going to identify different ducts which are going to form a pathway for the passage of the sperms. So intratesticular genital ducts, already I told you, so it is from the tubular recti, straight tubules joined to form the rete testis. From the rete testis, they are going to give rise to the ductuli efferent. So all these will be seen almost in area of merging part of the testis with the epididymis. So this is the region of the confluence from the testis to that of the epididymis, where you can see identify the efferent ductules. So where these tubular recti are going to empty into rete testis, which is an anastomotic network, and this give rise to efferent ducts. So what the epididymis consists of is mainly the efferent ductules. Okay, so the head of the epididymis, especially the cephalic portion, it consists of mainly the efferent ductules. So here in picture, so this is a section of epididymis. So this epididymis or the ductus epididymis will be having three portions. One is the head, then the body, then the tail. So still in the cephalic portion, you can see the sections of the seminiferous tubule. So these are present within the efferent ductules now. So in the testis, we have identified seminiferous tubules which are within the lobules. So here it is a section of the efferent ductules where there is a lining epithelium which is going to line the whole of these ductules. So this lining epithelium will be in the form of pseudostratified columnar epithelium. So initial portion it will be usually simple columnar, but as it further moves, it goes for a pseudostratified columnar cells. So where they will have a basal cells and there will be a tall columnar cells. So why it is called pseudostratified? It gives the appearance of stratified, though it is not stratified. So that is because of the different arrangement of the nuclei, because of the tall and short columnar cells. So where they are going to give an appearance of 2 to 3 layered nuclei. Okay. So this pseudostratified will be having one more feature, which you can see in the near the apical portion. So there are microvilli which are projections from the surface of these cells. So these are called the stereocilia. Though they are cilia, but these are immotile. So that's why you call them as the stereocilia. Okay. So the stereocilia can be identified in the apical portion, and what you see in the center of each part of the section will be the spermatids along with the spermatozoa. So complete spermatozoa is mature only when it enters into the female genital tract. So till that it will be immotile, but it has transformed from the spermatid into the next stage. Okay. So those are identified in the central portion of these ducts. Then this is a section of the vas deferens. So the tail portion of the epididymis continues next as the vas deferens. So vas deferens will be having 3 layers, especially which is a very narrow tubular section where you can see centrally a small lumen. So where it is a star-shaped lumen, and it will be covered by a lamina propria and a muscular tissue. So usually these slides we get confused with the urethral sections in case of students. Usually we differentiate by the lining epithelium. So there it is usually the transitional epithelium. So here we have identified the pseudostratified epithelium. So again it is the same. In the beginning it will be simple columnar. As it proceeds further, it will be the pseudostratified epithelium with the cilia, some and the lowermost portion. Then there is a connective tissue layer which is surrounding the epithelium, so which you call it as lamina propria, where it will have the blood vessels, lymphatics, and the nerves. Then surrounding that there is a muscle layer. So muscle layer here is differentiated into 3 layers. So we have the inner longitudinal, then there is a circular layer, and outermost will be the longitudinal again. So 3 layers of the muscles have been identified: inner and outer longitudinal, middle circular. Outermost layer, it will be covered by just thin serous membrane. So that is a section of the vas deferens. So further going into the different parts of the ductules. So the dilated portion of this duct is where it almost terminates. So that portion you call it as ampulla. So this is the only portion where the lumen can be identified a little bit larger one when compared to the rest of the duct. So this is the ampullary portion where you can see the infolded membrane of the mucosa, almost giving a star-shaped appearance. And this is the point where it is going to join the duct of the seminiferous tubule, and it is going to terminate as the ejaculatory duct into the prostatic part of the urethra. So these are just a sections of the accessory genital glands, like in the form of seminal vesicles or the prostate. So they are also made up of the fibromuscular tissue. So there will be an epithelium, so which is covering a lumen. So they are called the follicles. So these follicles are lined by an epithelium. So it may be simple columnar to pseudostratified. Then surrounding that, you can see some of the connective tissue layer in the form of lamina propria with few smooth muscles, so which are going to contract and help in propelling the fluid further. Okay. So all these are just the sections of the accessory glands, so which can be identified. So efferent ductules. So differentiation, what you can make out from this one and the testis. So here you can see the section of a small ductule. So where it is externally lined by the smooth muscle and it is having the tall ciliated cells. So two types of cells are identified. One is the ciliated cell. The other one is the basal cell, which are short and they are more absorptive in function. Okay. So this is the picture, histological picture of an efferent ductule. So all these are the basic structure which are related to the gross and the histological picture of the different parts of the male reproductive system. So what happens if there is any damage to any part of it or there is any developmental anomaly? So that we'll just deal few of the applied aspects which are related to the testis and the epidermis. So most common is the absence of the testis, either on one side or it may be on both sides. So it is usually a developmental anomaly. So that you call it as monarchism if it is absent on one side, and it is anarchism if it is absent on both the sides. Then undescended testis. So we have seen a very beautiful video of the testis there. So how it descends from the abdomen to the scrotum. So the pathway of this descent, if it is hindered or it is not happening properly during the development in any of the part, so it get arrested at these positions, whether it may be a lumbar one or it may get arrested at the iliac region or within the inguinal canal or it may be the upper scrotal region. So that's why it has not descended into the testis scrotal bag properly. So this descent, how you differentiate it from the ectopic testis? So ectopic testis is different from undescended testis. So ectopic it is present just beneath the skin, anywhere in and around the perineal region. It may need not be the pathway exactly what. So undescended it is obstructed anywhere during its path from the abdomen to the scrotum. But here ectopic is presence of the abnormal area, present in the abnormal area, which is usually normally found. So this may occupy the abnormal position, which is due to the deviation from the normal descent. So usually found under the skin, prepenile, or it may be above the scrotum. Then you have the hermaphroditism. So where there is intermixing of the features of both male and female. So this is called intersex. Most of the times it will be chromosomal and it will be congenital. So where both features of male and female can be identified. So the secondary sexual characters will not be properly developed and there will be intermixing of features. So true hermaphroditism is like where the testicles or this will be present, but secondary sexual characters will be different. So mixing. So that false, it may just give you a false resemblance to that, like either male or female, but it is not the actual sex. So that's how those two have to be differentiated. So this is what I was telling. So true, the undescended testis is the pathway is occluded anywhere along its descent. So from the abdomen to the scrotal region. So it can be found here in the inguinal region or just above the suprascrotal region. So whereas ectopic is present other than the normal pathway. So which is usually found beneath the skin. So it will be in the form of either peripenile or it may be femoral. So that may go to the thigh region. So all these abnormalities, they ultimately affect the fertility of the individual. So there may be improper development of the spermatogenesis process. So that give rise to whole of the spermatogenesis will be affected and individual may become infertile. So all these testicular fluid. So one more variety is the hydrocele. So where the fluid gets accumulated in the processus vaginalis. So processus vaginalis is a peritoneal cord, so which we have already seen, which is going to cover the testis through its descent. So if this descent is having a fluid accumulation, because the pampiniform plexus of the veins, which you are going to drain. So testis is applied by the testicular artery, drained by the pampiniform plexus of the veins, which form 4 veins at the superficial inguinal ring and 2 at the deep inguinal ring. Ultimately, they form a testicular vein. On the right side, it drains into inferior vena cava, whereas on the left side, it is going to drain into the left renal vein. So anywhere this accumulation of the venous blood, that dilatation of these vessels, it is going to lead to the edema. And this will be in the form of the accumulation of the fluid within the processus vaginalis. So if this tunica vaginalis is involved, only the tunica vaginalis is involved, you call it as a vaginal variety of hydrocele. But if it is infantile, that is in case of it extends up to the level of deep inguinal ring. So the fluid accumulation, it goes up to the level of the deep inguinal ring. You call it as an infantile variety. And congenital, usually the whole entire processus vaginalis remains patent. So it will be open and anything can get accumulated and it can lead to various anomalies. And encysted is only a small portion of it will be involved, like middle part, it may remain patent and it can lead to different varieties. These are the 4 varieties which have been identified as vaginal, infantile, congenital, and encysted variety. So one of the commonest reasons for the infertility will be the infections and the tumors of the testis. So one more birth control measure, which is normally done is the vasectomy. So this is where it is an elective surgical procedure where the male sterilization is done by the vas deferens is either cut or tied or it is sealed to prevent the further sperm entry. That is thereby preventing the fertilization in case of females. So it is the commonest procedure for birth control method. So these are the different applied aspects which are related to the testis, which we have been identified. So where there is an epididymal cyst, so which you usually call it as the spermatocele. Then if it is a dilated scrotal veins, so then it is going to lead to what is known as varicocele and epididymitis. So where there is only inflammation of the epididymis. Then you have orchitis, that is the testicular inflammation. Whole of the testis is in. Hydrocele already approved, so it will be accumulation of the fluid within the peritoneal sac within the processus vaginalis. Then testicular torsion or the twisting of the whole of the spermatic cord. So it is going to present as a severe pain which is radiated along the groin region and usually found during the accidents or in the fall of the groin. So all these are a part of the male reproductive system. I have tried my best to give out the anatomy of the male reproductive system and that of the histological part. So I thank Principal Madam and Degavi sir and all the HODs and the staff for giving me this opportunity. Thank you.
Thank you, ma'am, for enlightening us with your great knowledge. Now the session is open for discussion. If you have any queries, you can ask. I request dignitaries, Madam, to give a certificate as a token of love and gratitude. I request Dr. Sampada ma'am to come over the dais. Please, ma'am. We have Dr. B.S. Prasad sir for this virtual inauguration. Thank you, sir, for joining with us.
Alina. Including government of Karnataka. I also compliment this very good work to all of you. Let me compliment the succeeding in this part of the year by establishing another first of its kind prepared for meeting. I think, to my knowledge, the first time of that sector in Karnataka, it is the right of this, I must congratulate the entire team. I also compliment the students for that very high knowledge in this laboratory. And the one of the specialty of Ayurveda is having a bright future. To my knowledge, explain past and the present times and the future past. I say that the Vajikata, Swastamita, Shastra, the other these branches have very bright future in the coming days because of the changing trends and the changing health requirements. These branches have good role and responsibility to play in the coming days. And Vajikata, as already mentioned, now the treatment for infertility, sexual dysfunctions, as well as design improvements. Is very, very hot in India and very much more the years we call design, which is the period of the hour, and we need to concentrate. What I always see, they concentrate more on the treatments on the yogas than the disease process of the process. So I request all the professionals to concentrate more on the disease process, standing up with the manifestation and then simply by not letting yogas is not good. So we need to have very clear understanding of this process and some of the generally that's already well mentioned. So we need to understand this generally otherwise it's a not system or I should call it number stamp treatment, which is not professional practice. So we need to concentrate on the disease process. And also we need to develop the branches. So unless we concentrate and develop the branch will not then only get identified as in the setting. Otherwise, So we need to concentrate on practical growth of this child. Generally, as the specialty practice of so I have I watching that as then only we have to accept this. Otherwise, it's a nervous system or I nervous system. Then only you will be identified as in the section. Otherwise, so we need to concentrate on practical growth of this child. As a the specialty practice of so I was watching that as for the
Thank you, sir, for your valuable word. Next, we will have one more session. I'm very much delightful to introduce today's one more speaker, Dr. Arun Kumar sir. Sir was born on 19th August 1969. Sir passed their MBBS degree in 1992, J.J.M.C. Davangere, Mysore University. Pursued their MD Physiology in 1998 from Government Medical College, Ballari, Gulbarga University. Sir has working in Department of Physiology, BIMS Ballari from past 25 years. Sir has 14 years teaching experience as a professor for DNB, PG, UG, medical, dental, nursing, and lab technician students. Sir worked as a deputy medical superintendent for 5 years. Sir published about 10 research papers indexed in national journals, 2 research papers in international journals. Sir presented oral presentation in National Conference 2003 held at Bijapur. ECG changes in asymptomatic healthy individuals. Sir has recognized as a PZ guide in RGHS, panel of examiner in PZ and UZ in RGHS, NTR University, KAYACHIKITSA University, MCR University. Sir was appointed as a evaluator for peer reviewing of dissertation. Sir was appointed as a subject expert in interview panel of various government medical college for the recruitment of professor, associated professor, assistant professor in physiology. Sir worked as a MCA inspector also. Thank you, sir. I request sir to begin the today's session on physiology of male reproductive system.
So good morning, everybody. Actually, I am a little bit nervous by listening to the very good speech from Dr. Sampada. Are you able to hear? So male reproductive system, already you are familiar with the anatomy. So we'll straight away go how the male reproductive system it is developed. So if you look at the development aspect, the humans have 22 pairs of autosomes and 1 pair of sex chromosomes. So male, it's mainly because of the XY, that's the Y chromosome, sex chromosome. That is the main difference. So extra X chromosome, what is there in female, it is observed as a bar body in the neutrophil. Sex differentiation begins from 6th week of pregnancy. So until 6th week, it's the same. From 6th week, the development of either male or female starts. So this is the bar body seen in neutrophils. So if you look at this, see here 44XY, 44 the X and Y. There are bipotential say till 6th week of pregnancy. Then the SRY, that is the sex determining region on the Y chromosome, short arm of the Y chromosome, that develops into embryonic testis. See here, the important point to be noted here is the embryonic testis. It produces the testosterone. Not only that, it produces the Mullerian inhibiting substance. See here, the Mullerian inhibiting substance. So, which will inhibit the Mullerian duct. Mullerian duct is the one responsible for the development of female internal genitalia. Then the testosterone responsible for the development of male internal genitalia. Then dihydrotestosterone. If you look at this, testosterone is converted into dihydrotestosterone at the target tissue by the enzyme 5-alpha reductase. See, this dihydrotestosterone is the one which is responsible for the development of male external genitalia. And also this dihydrotestosterone, male secondary sexual character in adults. Again, DHT, that is the dihydrotestosterone, is very important. The fetal testosterone also acts on the brain. That's a male brain. Male behavior is mainly because of the action of the testosterone. So the important point here we should note is the dihydrotestosterone active form, which is responsible for the development of male external genitalia. So this, if you observe, you have the Wolffian duct and the Mullerian duct. So Wolffian duct, this Mullerian duct inhibiting substance, that is the secreted from the Sertoli cells. So Wolffian duct is the one which develops into the vas duct. So for this you require a testosterone. So this to show you the testosterone converted into dihydrotestosterone, which brings about the transcription changes, brings about the changes in the functioning of the cell. plays a major. So this is the sex determinant reason why chromosome that present short arm. So if there is any non-disjunction of the sex chromosomes, so it can lead to some of the chromosomal abnormalities. So one is the Klinefelter syndrome, that is where 42 XXY. So here usually the person will have seminiferous tubule agenesis and mental retardation is common with the Klinefelter syndrome. Klinefelter syndrome is the most common chromosomal abnormality that is seen with the 44XXY. And you also have the Turner syndrome. These are all the developmental defect, that is the chromosomal aberrations that are causing the defect. So here again, short stature, then agency, that is the ovarial ovaries are atrophied, that is not developed, and amenorrhea. Amenorrhea is the one that loss of lack of menstruation. So that is the one common feature with the Turner syndrome. Then the pseudo-hermaphroditism. So pseudo-hermaphroditism means genetically one sex and the external genitals are different. Here, if you observe, female pseudo-hermaphroditism, genetically female with the male external genital. We call the condition as female pseudo-hermaphroditism. So, especially exposure to the androgens between 8th and 13th week of gestation may cause female pseudo-hermaphroditism. One of the reasons. The another one is the male pseudo-hermaphroditism. Here, genetically male with the female external genital. So this is the one wherein the child will be grown up as a female. It will be grown up as a female. Only they come to the doctor that there is no maturation. So here, what happens? The genetically male with female external genital, and then at the age of say 12 years, she becomes he. So here, what happens? Why there is a developmental defect? Say one of the cause here is the absence of 5-alpha reductase enzyme. As I told you, testosterone needs to be converted to dihydrotestosterone for the development of male external genital. So congenital deficiency of this enzyme can lead to male pseudo-hermaphroditism. And then puberty, wherein the endocrine gametogenic functions of the gonads acquire the capacity to reproduce. So 8 to 13 years of age in girls and 9 to 14 years in male. Increased secretion of GnRH and FSH causes the puberty. So the cause for the puberty is the pulsatile release of GnRH. So what exactly makes the pulsatile release of GnRH? The exact reason is not known. Maybe leptin may be involved. Leptin, as you know, is secreted by adipose tissue, fat tissue. So what happens? It is puberty is related to the body weight. Say in athletes, that means those who where there is a loss of weight are patients with anorexia nervosa, where the body weight is less. So in them, the leptin is less, the fat tissue is less, leptin production is less. So there puberty is prolonged. So there they say leptin somehow influences the production of GnRH. And then another condition you should know is the precocious puberty. So early onset of puberty with the secondary sexual characteristics in children, the development of secondary sexual characteristics before 8 years of age in girls, 9 years in boys. So the cause could be tumor, tumor, whatever it is. Delayed puberty seen where span hypopituitarism. So this is about the development aspect, how the male reproductive system develops from the fetus. Then you have the organs of male reproductive system to take testes. So in most of the animals, the testes lie in the scrotum, except say, lumbar region, say elephants, reptiles, and then inguinal canal, seal, and then seasonal migration to rodent. So the reason for the scrotal selection, so if you observe, it is the reduction in the temperature, the air conditioning, that is the sac surrounded, covered by the skin and the layer of smooth muscle, that's the data. The cremaster muscle also attached to the scrotum. So ideal temperature for sperm production is 95 °F. So this is dependent upon the temperature. Depending on the temperature, the two muscles either contract or relax, pulling the testis closer to the body. That is the adjustment of the position of the testis so that the temperature is maintained. So another method of maintaining is the countercurrent mechanism, where it is occurring between the testicular arteries and the veins. The exchange of heat taking place, which will also reduce the temperature. So that is why what they say, if a person is taking hot water bath for nearly 30 minutes, then observe that the sperm count is reduced. So that is why they say the temperature needs to be maintained at the lower level. And then the seminiferous tubules, each testicular lobule, the seminiferous tubule, site of sperm production, 1.3 feet in human. Total length of seminiferous tubule, almost the length of a football field. So much. So this, look at the histology aspect. So the one is the proper tubule, then the interstitial space, that is the Leydig cell for androgen production. The seminiferous tubules lined by germinal epithelium. So only two types, the germ cell and the Sertoli cell. So outside the seminiferous tubules lie the Leydig cell, responsible for androgen production in response to luteinizing hormone. So this luteinizing hormone is secreted from anybody? LH is secreted from anterior pituitary. So this is the Leydig cell, the Sertoli cell, the spermatogonium. So the structure of the Sertoli cells. So you look at the functions of the Sertoli. Sertoli cells are joined by tight junctions that provides the barrier to chemicals. Blood testis barrier. The tight junctions between the Sertoli cells. So this will prevent any toxic material from the blood entering into the germ cell, that's in the seminiferous tubules. then this will also prevent any antibody reaction, autoimmune reaction. Say, for example, the entry of the sperm into the blood. So it can also produce an immune reaction that is also prevented. Then the Sertoli cells nourish the developing sperm. They secrete luminal fluids, including androgen binding protein, ABP. Androgen binding protein is the one secreted by the Sertoli cells responsible for the higher concentration of testosterone within the seminiferous tubule. So that is required for normal spermatogenesis. They phagocyte the sperm. They mediate testosterone and FSH effect on spermatogenesis. They secrete inhibin, which inhibits FSH secretion. See, the Sertoli cells under the they are stimulated by the FSH. It produces inhibin, which in turn inhibits the FSH secretion. So that's a negative feedback mechanism to control the level. Then they influence the Leydig cells via the paracrine secretions. The embryonic secretion of Mullerian inhibiting substance that ensues male phenotype. So in the embryonic testing, these Sertoli cells, they produce Mullerian inhibiting substance, MIS. So that inhibits the Mullerian tract. So that prevents the development of female genital tract. So that is the one of the function. So mainly the MIS and this androgen binding protein especially required for spermatogenesis. Then the blood test barrier limits the fluid transfer between the abdominal and the basal and interstitial compartment. So prevents gametes entering the interstitial space. So the two compartments are separated by blood testis barrier. It is mainly because of the gap junctions, the tight junctions between the Sertoli cells. So they form the barrier. So they prevent immune response to foreign protein of the gametes, even the sperm granuloma is also prevented. So the spermatogenesis already it's covered, the process by which sperm develops to become mature sperm capable of fertilizing the ovum. Every day, 300 million sperm complete spermatogenesis. So this is the structure of the sperm. The head, acrosome. So this is acrosome is important. A cap-like vesicle filled with oocyte penetrating enzyme that help the sperm to penetrate secondary oocyte. So that means they have a proteolytic enzyme, protease, the hyaluronidase, which helps in the penetrating to the oocyte. Then the tail, it has the neck and the middle piece mitochondria. They provide the energy. Once ejaculated, sperm do not survive more than 48 hours in female reproductive tract. So that becomes the one of the basis for calendar method of contraception. That means ovulation occurs say on 14th day. The ovum doesn't survive, say, capable of fertilizing after 72 hours. So 2 days before ovulation and 3 days after ovulation. So it is calculated in the calendar method of contraception. So this the spermatogenesis from the primordial germ cell to the sperm. During the formation of the embryo, the primordial germ cells migrate into the testis and become immature germ cells called spermatogonia. Immature sperms are called spermatids, one primary spermatocyte will produce 4 mature sperm. So sperms gain motility in epididymis. So final capacitation occurs in the female reproductive tract. So for production of the sperm, it takes around 65 to 75 days. The duration required for the production of sperm. So it begins with spermatogonia. The stem cells undergo mitosis to replace themselves and to continue development. See here, if you observe renewal of the cells, and then there is a differentiation both taking place. So renewal for further production of spermatogonia. So this you have the meiosis 1 and 2. So the cells remain attached to each other by the cytoplasmic bridges. Spermiogenesis, the development of spermatids into the sperm, a spherical spermatids transform into elongated sperm. Acrosome and flagella form mitochondria, multiply. Sertoli cells dispose of excess cytoplasm. So that is the spermiogenesis. You can observe spermiogenesis, the cytoplasmic bridge. So the factors affecting the spermatogenesis, there are many factors. The lifestyle, that means the alcohol, the smoking, which will affect the occupational work, exposure to radiation. It will also affect the environmental factor, the diabetes. There are many factors which affects the production of the sperm. So hormonal factors that stimulate the spermatogenesis: testosterone, luteinizing hormone, follicle stimulating hormone, even small amount of the estrogen, the growth hormone. So hormonal control of the testes, at puberty, secretion of the gonadotropin releasing hormone increases. It stimulates the anterior pituitary to increase the LH and FSH. It is the GnRH which stimulates the LH and FSH from the anterior pituitary. The LH stimulates the Leydig cell to secrete testosterone. So luteinizing hormone acts on the Leydig cell. So the testosterone production is increased. It is synthesized from cholesterol, mainly in the testes. So suppression of secretion of LH and GnRH by an active feedback. The testosterone, when it is in excess amount, it will inhibit the production of the GnRH and the LH. So that's a negative feedback control. And then enzyme 5-alpha reductase converts testosterone into dihydrotestosterone in external genitals and in the prostate. So here in the prostate also, it is the DHP that is responsible for the development. So here, the testosterone influences the spermatogenesis. Then FSH acts indirectly on spermatogenesis. So FSH, testosterone act on Sertoli cell to stimulate the secretion of androgen binding protein. So this androgen binding protein binds testosterone, keeping concentration high. So testosterone stimulates spermatogenesis. The Sertoli cells release inhibin, which inhibits the FSH. So that means a negative feedback control. So here one point you should note is the testosterone stimulates spermatogenesis. Is it correct? So if the sperm count is less, can we give testosterone injection? Will the testosterone improve the sperm count. So in other words, it's a patient coming with the low sperm count or agiospermia, had the history of taking testosterone injection for a long time. So will the testosterone cause increase in sperm count or decrease in sperm? See, testosterone helps in spermatogenesis, right? So actually, if you give more of testosterone, so testosterone would have become one form of giving treatment for low sperm count. But the effect is not that. It's the reverse. If you give testosterone, the sperm count will reduce and the agiospermia is seen. So why it is seen? It is mainly because whatever the testosterone we give, by negative feedback mechanism, it will inhibit the production of the CNRH or the LH. So that will be reduced, one point. And another point is the local concentration of testosterone is important. The concentration of testosterone in the seminiferous tubules, that will be influencing the spermatogenesis. Whatever the external testosterone injection we give, so that is not the concentration in the seminiferous tubules is say 100 times more than what the systemic testosterone. So that means the testosterone will inhibit the production of the LH, wherein the endogenous production of testosterone is inhibited, and the local concentration of the testosterone is reduced. Ultimately, the spermatogenesis is reduced. That is why the testosterone doesn't become the part of treatment of to increase the sperm. It is the other way around. You give testosterone, sperm count will reduce. It's mainly because it negative feedback inhibition, one, and the second one is the local concentration of testosterone is not increased by giving systemic testosterone. Then you have the other hormone, the luteinizing hormone secreted by the anterior pituitary gland stimulates the Leydig cell to secrete testosterone. Then the FSH also secreted by anterior pituitary gland stimulates the Sertoli cell. So it stimulates the conversion of spermatids to sperm. Then the estrogen again formed from testosterone by the Sertoli cell under the FSH stimulation, also essential for spermatogenesis. Even the growth hormone, it also promotes the spermatogenesis. The influencing factors, the endocrine environment, temperature, dietary factors, radiation exposure, smoking, alcohol, the infectious disease, all these factors affect the sperm production. So if you look at the functions of testosterone, so prenatal development, testosterone stimulates the male pattern of development of reproductive system, and the DHT stimulates the development of external genitalia. That is the prenatal function of testosterone. Then in the adults, say the development of male sexual characteristics. At puberty, they bring about the development of male sex organ and the development of male secondary sexual characteristics. Then development of sexual function, the male sexual behavior, spermatogenesis. Then stimulation of anabolism. So anabolism is also important. They stimulate the protein synthesis, heavier muscle and bone mass. Heavier muscle and bone mass. This has been misused in the athletes. So in the competition, they take the anabolic steroids, so which will improve the muscle performance. So that is again detected by the doping test. So the excretion of the 17 keto steroids, the urine, again they are tested. So these anabolic steroids, they are banned in the sporting events. So then the testosterone production already, from the ladies in response to anterior the age of maturation of male stimulates production of sperm along with the FSH. So these are some of the actions the male secondary will, and then deepening of the voice, skeletal muscle development, increase in metabolic rate. They all even the increase in the RBC count. Again, the testosterone plays an important role. Then this is the how the testosterone production is regulated. See the GnRH from the hypothalamus. Hypothalamus, it secretes the gonadotropin releasing hormone, which acts on the anterior pituitary to release the LH and the FSH. The luteinizing hormone acts on the Leydig cells. Leydig cell, which produces the testosterone. So this testosterone local concentration is also increased here, and then any excess testosterone that is produced will inhibit the release of LH and the GnRH. So exogenous testosterone, suppose if we give testosterone injection, it will inhibit the LH and the GnRH production. Then the FSH will act on Sertoli cells. FSH acts on Sertoli cells. So these Sertoli cells will also produce inhibin B, which inhibits the release of FSH. This is the negative feedback control. So this is the regulation of testosterone level. So in order to maintain the testosterone level within the normal limits. So any excess, it will be inhibited. Any less production of testosterone, again, there is no inhibition on GnRH. So again, there is increased production of testosterone. So the male pattern of baldness, this is again because of the action of dihydrotestosterone. So function of the duct and accessory gland, sperm transport, sperm storage, sperm maturation, and production of semen. So this seminal vesicle, it produces 60% of the semen. Seminal vesicle, it forms about 60%, and then thick yellowish secretion, rich in sugar. Sugar, that is the fructose. Vitamin C, prostaglandins, and fibrinogen. Prostaglandins are also important. They nourish and activate the sperm, joint vas deferens on either side of the ejaculatory duct. Then the prostate gland, you observe donut-shaped prostate gland, milky alkaline fluid, approximately up to 30% of the semen contribution. Again, it is from the prostate gland. So anterior to rectum, it can be palpated by perrectal examination. So it also secretes the fibrinolysin. So increase in the prostate size, hypertrophy, again common in old age, above the age of 50 years. Above the age of 50 years, BPH, benign prostate hypertrophy, which causes the obstruction to the urine flow, urgency, frequency, of maturation. So that is why we usually say that 5-alpha reductase enzyme, which converts testosterone into dihydrotestosterone, if that is inhibited by the drug, then the dihydrotestosterone level will decrease, and even the size of the prostate will also decrease. Then the bulbourethral glands, Copper's glands, the first to empty with the ejaculation, it cleans and neutralizes the penile urethra, also a lubricant. So mature sperms, streamlined vessels needs nutrient source fructose from the seminal vesicle, need buffer that is from the prostate. Then prostaglandins cause smooth muscle to contract, fibrinogen and fibrinolysin, clotting, and then liquefaction. The inhibitors of female immune system, especially the prostaglandins, dilutes the sperm. So seminal vesicles, prostate gland, bulbourethral glands, all are involved in the production of semen. So the seminal vesicles secrete alkaline viscous fluid, high fructose content, comprises majority of the semen. So this alkaline nature is required for the to neutralize the acidic medium in the female reproductive tract. So prostate around 33%. So the benign prostate hyperplasia may occur in the old days. So if you look at the composition of the human semen, so the pH is around 7.35 to 7.5. The normal sperm count is around 100 million per ml, with less than 20% abnormal forms. That should be the normal count. And then from the seminal vesicle, the prostaglandins, fructose, there are important. And from the prostate, it's the spermine, fibrinolysis, and then the zinc. It's also important for the so this prostate contributes say up to 30%. Then by contrast, they act as buffers. So hyaluronate again the acrosome, which helps in penetration of oocyte. So if you look at the analysis, say from the testis, it's around only contribution is 2 to 5%. So seminal vesicle 65 to 75%. From the prostate 25 to 30%. So this slightly alkaline pH after 2-3 days of abstinence, the volume may be around 2.5 to 4.5 ml, and 100 to 125 million sperms per ml, normal sperm count. And this vasectomy earlier was done, shown as a form of contraception. See the abnormalities of the sperm, sperm count is 0, albuminuria, reduced sperm count. Usually, with the sperm count of 20 to 40 million per ml, about 50% of the men are sterile. If the sperm count is less than 20 million, they almost are sterile. So the sperm count is also important, and also the normal sperm count is also with the normal motility. So you have low sperm count, abnormal mobility. So these are defects in the head, then acrosomal defects, so neck and mid defect, tail defect. Some of the abnormal forms. So maybe you are all bored. I thought I will include these slides. You should avoid some of the bad habits. Should be alert. Wait. Perhaps what you are looking for will find you. So don't let the situation confuse you. You should be determined in achieving your goal. Always be ready for any surprises in life. Please listen to good advice. Don't stop. Curious. This one of the this is one of the MCQ. A male received testosterone for a long time, so it may cause, I was telling you, ageospermia. One of the I have some of the MCQs. You're interested, or we'll move to next topic. Stem cell. MCQs. Capacitance of sperm takes place in seminiferous tubule, epididymis, vas deferens, uterus. Answer is uterus. Sertoli cells associated with spermiogenesis, secretion of seminal fluid, production of testosterone, production of sperm. Testosterone is produced by ladies. Production of sperm, spermatogonium, germ cells. So spermiogenesis. Sertoli cells in the testes have receptors for which one? So which hormone from anterior pituitary will act on Sertoli cells? FSH. Then they will have the receptor for FSH. Sperms acquire motility in epididymis, testis, vas deferens, seminal sac. Epididymis. Which of the following hormones is secreted by Sertoli cells? Antibodies against sperm develop after infection, after vasectomy, after orchidectomy. None of the above. Lottery. After vasectomy. After vasectomy, the sperm products may be reabsorbed. It's observed that around 53% of the persons who underwent vasectomy developed the antibodies for the sperm. So this cannot be used as a method of contraception. Then, gene coding for androgen receptor is situated in that is the SRY, sex determining region of Y chromosome. Short arm of which of the following is inhibited by inhibin? FS. Meiosis occurs in human male. Seminiferous tubule. Sertoli blood testis barrier is formed by which cell? Prostaglandins found in seminal fluid are secreted from anybody? Seminal. Yes. Before the onset of puberty, the GnRH neurons are under the inhibitory control of it's the beta. So epiphyseal closure is due to anybody? Closure of epiphysis is one of the function of the androgen. Fructose is secreted by sex differentiation begins at chromosomal pattern in client spermatozoa will be viable in epidermis for about 1 month. The number of spermatids produced by single spermatogonium any guess? Single spermatogonium, it is 501. So this is about the yeah. Another small topic. So the stem cell and its uses. So the stem cells, if you take most of the research is going on these stem cells. So the definition, the characteristics of stem cell, types of stem cell, and its uses. So what are stem cells? Stem cells are specialized type of cells which have the ability to divide indefinitely and have potential to give rise to a specialized tissue of the body. See the two characteristics of stem cells. It can divide indefinitely, one, and then it can give rise to specialized tissue. Say heart can give rise to heart, muscle, the specialized tissue, and it can divide repeatedly. So characteristics of stem cell, you should know proliferation and differentiation and self-renewal. Self-renewal for future use. So if you observe here, the stem cell, the proliferation, differentiation, there is a change in the size, shape, that is the differentiation. Proliferation, again, increase in the number. So self-renewal, it can follow asymmetric or symmetric things. So self-renewal here, asymmetric refers to cell replication in which one daughter cell enters a differentiation pathway and gives rise to mature cells, whereas other remains undifferentiated and retains its self-renewal capacity. So that is the asymmetric division. A symmetric division, both daughter cells retain self-renewal capacity. So proliferation and differentiation, stem cells. See, totipotency, pluripotency, multipotency, unipotency. So this totipotency, the ability to produce any type of cell. So the stem cells, they are the, you can say, future treatment for many diseases, cure for many diseases. We are hardly able to cure the disease, but these stem cells, they form the basis. See here, totipotency, it can produce any type of cell, example, zygote. Then pluripotency, the ability to produce any cell lineage, that is, it can differentiate into germ cells. Then multipotency, the ability to produce any kind of cell within a cell lineage, say hemopoietic stem cells. It can give rise to one cell lineage, that is the blood cell. Unipotency, the ability to produce only one kind of cell, the hepatocytes. So this is the proliferation and the differentiation. See here you can see totipotent, zygote. So it can virtually give rise to any tissue. See this pluri and multipotent. So it will give rise to different tissues here with the one cell lineage. Types of stem cells. See, broadly, stem cells are classified into two types: embryonic stem cells and tissue stem cells. So, embryonic stem cells, most undifferentiated, they are present in the inner cell mass of blastocysts, have virtually limitless cell renewal capacity, and can give rise to every cell in the body. They are thus said to be totipotent. That is the embryonic stem cells. Then tissue stem cells, also called as adult stem cells, they are found in intimate association with the differentiated cell of a given tissue. They are normally protected within the specialized tissue environment called stem cell niches. See here, if you look at the differences between the embryonic and the adult stem cell. So it is a totipotent, differentiate into any cell type. Here differentiation into some cell type, limited outcomes. Let's say you can hemopoietic stem cell. Known source, unknown source. Large numbers can be harvested from the embryo. So limited numbers, more difficult to isolate. It may cause immune rejection. Less likely to cause immune rejection since the patient's own cells can be used. So the rejection of embryonic stem cells by the recipient has not been shown yet. So here if you observe, the totipotent stem cell can give rise to any type of tissues. See here, pluripotent, multipotent, then the committed lineage stem cells. Pluripotent again, the embryonic stem cells giving rise to say the liver and the cardiac tissue, then hemopoietic, then pancreatic islet cells. So sources and uses of stem cells, the ability to identify, isolate, expand, and transplant stem cells has given birth to a new field of regenerative medicine. So this source of stem cells will be peripheral blood, cord blood, umbilical cord blood, bone marrow. So uses of stem cells, basic research, even in biotechnology, cell-based therapy, gene therapy. So these are the uses. If you look at the research, basic research on stem cells has been carried out to better understand the molecular basis of cancer. Then biotechnology is used in the development of drug, in the screening, and in the response to the potential new drug for the treatment. Then the gene therapy. Say how stem cells and the gene therapy might work together. So a sample of bone marrow is removed. Stem cells are isolated and allowed to multiply in culture. Then the cells are treated with modified virus containing the therapeutic gene. So you are injecting the virus into the stem cell. The virus is taken up by the individual cells and the therapeutic gene goes into the cell nucleus. So the treated or the corrected cells are again injected into the bloodstream. The treated cells respond to the injury signals from the degenerating muscle or the tissues and migrate out of the bloodstream. So treated cells patch damage and build healthy tissue. So it's the gene therapy again. Majority of the diseases can be cured, genetic diseases. So you have the cell-based therapies. Regenerative therapy is used in the treatment of, say, the Parkinson's, Alzheimer's disease, spinal cord injury, severe burns, and so on. In the treatment of leukemias, bone marrow failure cases, so the cell-based therapies are also used. So it's an emerging field. It requires still more research work. So this is you can virtually say tissue repair, regeneration of spinal cord, heart tissue. Then in the heart disease, you can even replace the skin shooter. And even in rheumatoid arthritis, adult stem cells may be helpful in jump-starting repair of eroded cartilage in the rheumatoid arthritis. So this is about the stem cells. This is the hematopoietic stem cell transplantation. So best studied adult stem cell gives rise to all blood cells, well-established clinical use. Hematopoietic stem cell transplant. The type 1 diabetes, the pancreatic cells do not produce insulin in the type 1 diabetes. So insulin production is not there from the pancreas. So the basic research focused on understanding how embryonic stem cell might be trained to become pancreatic islet cell needed to secrete the insulin. So this is about some points about the stem cells. I thank you. One word I should say, hats off to the students for sitting quietly and not making noise and listening in spite of the boring lectures. So this first time I'm observing so well disciplined students. Thank you.
Thank you, sir. This is very much useful for all of us. Thank you. I request sir to come over the dais. Have this time to issue certificate for sir as a token of love and gratitude. I request dignitaries to give the certificate. Thanks.
Thank you so much for all your credentials.
Thank you all. Third session is followed by lunch, sharp at 2 p.m. Thank you all.